invited me to your meeting. So I was asked to talk to you about asymptomatic bacteriuria versus UTI in long-term care patients. So it's a very common condition in this patient population, so I certainly think it warrants some discussion. So I do have some questions during this presentation, which I'll ask April to load the polls when it's time, and then I'm happy to take any questions at the end of the presentation. So I don't have any disclosures. So these are the objectives of the talk today. So I'm going to talk about the epidemiology of asymptomatic bacteriuria, walk you through what real UTI symptoms are and highlight the ones that are not, how to interpret urine tests in elderly patients, and then give some advice on how to reduce inappropriate testing and treatment of asymptomatic bacteriuria in long-term care residents. So this is the first case. There's two questions here. You have a 65-year-old man with osteoarthritis. He's noticed some foul-smelling urine, but no pain or difficulty with urination. A urine dipstick was done, which shows trace blood. So the first question is, do you prescribe antibiotic?
Can you guys see the poll? Oh,
Are
yeah.
all three questions supposed to show up at the same time?
I think they're, well, there looks like they're being answered, I think. Yeah, they're being answered.
Okay, yeah, I just answered the first two. And what is the probability of UTI in this patient?
Six people have answered so far.
Number three is not part of this case.
Yes. Sorry about that. I'll enter it in again in the next one.
Okay, don't answer question three, just one and two.
Like most people have stopped answering, so I'm going to end it and then you'll see the answers.
Okay, so 90% said no antibiotics, 30% said less than 1% probability of UTI, and then 50% said 10%. Okay, so I'll show you the results of this study. So the previous case was actually used in a survey study testing clinicians' ability to estimate the risk of having a UTI based on that limited information that you saw there. So these are the distribution of responses by participants. So on the left diagram, people were asked to estimate the risk of UTI before getting any urine culture. So you can see there's a wide range of answers. Many hovered around 0 to 20%, similar to what you guys answered, but most of you were saying it's less than 1%. But what's concerning is many others thought the risk was higher, 40% or more. And so you see the evidence-based answer is that vertical yellow bar there. It's basically sitting at 0, right? In the middle graph, you can see how the responses now kind of shift all the way to the right if you have a positive urine culture. And some were estimating the probability to be somewhere between 80 to 100%. And the blue bar there is the evidence-based probability. It shows a wider confidence interval, but it still includes 0. So then on the graph on the right, you see that this wave of responses shift towards the left, towards 0, if the urine culture is now negative. And the evidence-based probability still is at 0, right? That green thin bar there that you see. So asymptomatic bacteriuria by definition is not a UTI, so 0% makes sense regardless of the urine culture result. So what concerns me is that the clinicians who participate in this study seem to have a lot of faith in the value of a urine culture to diagnose or exclude a UTI. But in reality, the symptoms matter most. It's not the urine tests. So I'm glad you guys did better than the participants in the survey. So I'm sure you guys all know that bacteriuria is very common, especially in elderly people, and it gets more common as you get older. So up to 50% of females and 40% of males in long-term care have bacteriuria. And if you have a urinary catheter, you are virtually guaranteed to have bacterial colonization within a month. But the vast majority of these patients don't end up developing a real UTI. It's only less than 2%. And as you all know, urine testing is very common in this population. Up to 80% of patients with asymptomatic bacteriuria get testing. So it's really hard to know when a practice is inappropriate when most people are doing it, right? And the ones who are following the guidelines appropriately might look like the odd ones out. And so when people overtest, there's a higher chance of finding false positives. So it's hard to ignore a positive result. And so patients end up getting treated with antibiotics. And so this might make the clinician feel better that they're doing something, relieve some anxiety, even though this intervention might be causing harm to the patient. So there was a cohort study of just over 2,700 hospitalized adult patients with asymptomatic bacteriuria, and they found that over 80% received inappropriate antibiotic treatment. And these patients tended to be older, they had altered mental status, abnormal urinalysis, and they found that antibiotic treatment was associated with a 37% longer duration of hospital stay without any improved clinical outcomes. And the risk factors for over-treating these patients were clinicians were treating lab findings without correlating with the clinical picture. There were some psychological factors such as anxiety, they're being overly cautious, or they expected a positive outcome with the antibiotic. Sometimes there's external pressure, such as institutional culture, peer pressure, patient expectation, and then excessive workload that maybe interferes with proper decision making. Sometimes it's easier just to give the drug than work things out more carefully. And sometimes it's difficult to interpret clinical symptoms and signs of the population. Many times they're delirious. They can't really tell you what symptoms they have. And in a completely different study, they asked clinicians, would you prescribe antibiotic in that previous case that I showed you? So remember, it's a 65-year-old man with osteoarthritis. He had foul-smelling urine, no dysuria, but he had some trace blood on dipstick. So this was in a different study. They asked them if they would prescribe antibiotics. So it's a pretty good response rate of 76%. I think they got like a Starbucks gift card or something like that to encourage them to participate. But what was concerning is that 71% said they would give antibiotic, which is quite remarkable, right? But they weren't told that this is a case of asymptomatic bacteriuria. They had to figure it out for themselves. And then people who prescribed antibiotic naturally estimated the risk of UTI to be higher than those who did not prescribe it. And respondents who were deemed to have a low numeracy score, meaning that they weren't very good with numbers and probability, and they had high medical maximizing tendency, meaning that they possessed an attitude where more care is better. So those people were more likely to prescribe antibiotics. So what actually counts as a UTI symptom? So this has been studied. This is what the evidence says counts as a true UTI symptom and sign. So these were derived from young women in their 20s, so they may not be accurate in older folks. So you see here that dysuria, urinary frequency, hematuria, back pain, costovertebral angle tenderness, and absence of vaginal discharge or irritation all increase the probability of having a UTI. And the more of these that you have, the greater the likelihood. And looking at the bottom there, symptom combination. If you have um, dysuria frequency in the absence of vaginal symptoms, then the chance of you having UTI is basically very, very high. So 96%. So that's why the recommendation in primary care is if you have this high of a probability, I don't even bother, doing the urine culture. All right. But remember, these symptoms are validated in young, healthy females in their 20s, 30s. So it might not be as accurate in older people. So notice what symptoms are not included in this list. So you got foul-smelling urine, cloudy urine, and change in mental status. So these are common symptoms that people often misattribute to UTI. So foul-smelling urine could be from dehydration, maybe from diet. Cloudy urine could also be from dehydration. Altered mental status, very common in the elderly. And it can be caused by so many different things, right? But it's commonly thought to be triggered by UTI because so many of these patients have abnormal urine tests. Um, Also, if you have urinary retention and gross hematuria, those are sometimes attributed to UTI, although they can be, but not on their own. So if someone had urinary retention or hematuria, I would expect them to have some other accompanying UTI symptom, right? Okay, this is case number 2, so corresponding to question 3 from the poll. You got a 90-year-old female from a nursing home who's admitted to hospital with delirium. She has no localizing symptoms or signs. She's afebrile and otherwise stable. Um, so urine test was done. It was positive for nitrite, leukocyte esterase. There's more than 100 mega CFU per liter of Klebsiella and ammoniate. There's her electrolytes, a little bit of hypokalemia, hyponatremia, bit of AKI, white count 12, um, lactate 1, CRP 30. So this is a pretty common scenario we see in hospital. And the question for you guys is, what do you want to do? So do you start empiric antibiotics to treat a UTI, repeat the urine test, assess for causes of delirium, or IV fluids, plus assess for causes of delirium, plus empiric antibiotics to treat a UTI?
So people are answering. Another quick second here. 11 people have answered. Looks like it's slowing down here. Okay. I'll go ahead and I'll show the results.
Yeah, so it's pretty much almost an even split between answer C and D. I know this one is a little bit tricky. So the point of this case is to highlight a common scenario and what we commonly do. So answer D is what people almost always do. And, it's very hard to know whether or not this is from a UTI. But basically, all the wrong answers are the ones that fixate on the urine. So A and B and D. So D is only partially correct with giving IV fluids and looking for causes of delirium, but it's wrong because it says you start antibiotics to treat a UTI. Okay, so C is the most correct because it does not fixate on treating the urine results. So the main task here is to look for and treat the cause of delirium. Okay, so at baseline, having an abnormal urinalysis or positive urine culture could be a normal finding in these older people, right? So then the positive predictive value of urine testing in this population is quite low, right? So pyuria can also be caused by other conditions other than UTIs. Could be from intra-abdominal infections, pneumonia, inflammatory conditions, certain medications such as PPIs, renal disease. So it's really not specific. And if you rely on pyuria or bacteriuria alone to diagnose a UTI, this leads to overtreatment in almost half of the cases. But it can also lead to undertreatment, because the urinalysis and urine culture are not perfect. So sometimes it can be falsely negative if, if they're on previous antibiotic or they're immune compromised. So you really have to consider the pretest probability of the disease before ordering the test. Otherwise, you're more likely to end up with false positives or false negatives. So when you look at choosing wisely recommendations across multiple disciplines, a recurring theme appears. So they basically say that you don't rely on urine dipstick or urinalysis to diagnose UTI in elderly patients. Also, don't assume UTI is the cause of altered mental status in this population. You should look for other causes first, like dehydration, constipation, drug side effects, other sources of infection, etc. So choosing wisely also says don't obtain a urine culture unless these minimum criteria are met. It's called the Loeb criteria. So there are criteria for non-catheterized and for catheterized patients. So if you don't have a catheter, then sending off the urine is reasonable if you have um, acute dysuria alone, or if you have at least two of the following symptoms. So new or worsening urinary urgency, frequency, bladder pain, gross hematuria, CV tenderness, or new urinary incontinence. So you see here with gross hematuria by itself, it doesn't count. You have to have another symptom to accompany it. If you have a catheter, then you only need one of the following criteria. So fever, new CV tenderness, rigors without another cause, and then new onset delirium NYD. So you are allowed to send a urine if you have a catheter, if there's no other cause of delirium. So does applying these criteria in practice actually work? So this was actually studied in an RCT 20 years ago where they randomized over 4,000 long-term care residents to the intervention group or the standard care group. So intervention was they included algorithms like the Loeb criteria, education, written handouts, and interviews with clinicians. And after implementing this algorithm, they discovered that there was a 31% reduction in antibiotic use in the intervention group, and no extra harm was caused. I mean, I would argue that reducing unnecessary testing and antibiotic use should actually decrease harm. So if they were to measure the difference in harm, it's probably lower in the intervention group. This is an algorithm from AMI. It's the Association of Medical Microbiology and Infectious Diseases of Canada. And I like this one because um, it's nice and colorful, but I think it also is quite comprehensive. So it guides you on appropriate urine testing in elderly patients without a urine catheter. So you start at the top box. If you have acute dysuria all by itself, uh, or if you have at least two of the other symptoms listed there, then you can order a urinalysis and urine culture. So these are basically the Loeb criteria. So ideally, the urine culture should be processed only if the urinalysis shows pyuria. So what this means is you have positive leukocyte esterase, or you have more than 5 white blood cells per high power field. But that depends on the lab. So in Fraser Health, the lab will not restrict urine culture based on a urinalysis. So you can order a urine culture without a urinalysis, no one's going to stop you. In practice, though, the urinalysis and urine culture are sometimes obtained at the same time, just for practical reasons, right? And if you don't have pyuria, then it's very unlikely that you have a UTI, right? Because if you have a UTI, you expect white blood cells or inflammation in your urinary tract, either in the form of leukoesterase or white cells per high power field. So moving down the algorithm, if the urinalysis shows pyuria and the urine culture grows 1 or 2 organisms, then you treat as UTI. Then you can see that every other pathway leads you away from treating for UTI. And then notice if you just have altered mental status on the far right there, without any localizing UTI symptoms, the algorithm steers you away from diagnosing a UTI. Instead, it prompts you to consider other causes of altered LOC. And so this would be a nice poster to hang up at all long-term care facilities, just as a reminder that UTIs are not as common as people think they are. So we often use the term UTI indiscriminately, but it's kind of ambiguous, right? So UTI can refer to infection of any organ in the urinary tract. So the bladder, the ureter, kidney, prostate, testicle. So it's important to know what language we're speaking, right? Make sure we're on the same page here. So these are just very two simple definitions, and it's been updated over the past several years. So uncomplicated UTI refers to infection only of the bladder. So you should not have any systemic symptoms. You should not have any flank pain or costovertebral angle tenderness. So if it's just bladder infection, your symptoms should only be localized, nothing systemic. If you have a complicated UTI, this means that your infection is spread outside the bladder. So either kidney, ureter, prostate, testicles. You might have systemic symptoms. You're going to have flank pain, costovertebral angle tenderness. If you examine the prostate, it might be boggy or tender, or you might have a tender swollen testicle. But for the most part, we're going to be talking about pyelonephritis, not so much prostatitis or orchitis, epididymitis. With regards to catheter-associated UTI, the symptoms are going to be different than someone without a urinary catheter. So since you're not using your bladder to void, you're not going to feel the typical bladder symptoms such as dysuria, frequency, urgency. So most likely these infections are going to be complicated. And if you have a kidney infection, you're going to have flank pain, fever, nausea, probably delirium. And when you collect the urine, do not collect it from the tubing or the bag. These areas are likely going to be colonized with all sorts of different bugs, so it's not representative of the actual pathogen. So the textbook answer is you get a fresh urine from a newly inserted catheter. In practice, I know this is not often done because of limited time and resources, but if you do collect it from the tube or the bag, be aware that garbage information in, garbage intervention out, right? So these are two local resources that you may or may not know about. You can access for treatment recommendations on UTI and other common infections. So First Line is designed for use in Fraser Health, while Bugs and Drugs is a resource for BC and Alberta clinicians. So they're regularly updated with new data and guidelines, antibiogram information as well. So you can download both of them as apps, or you can view the content on the websites. So I won't go through the recommendations for every type of UTI, but because it's pretty straightforward. But I will highlight some basic treatment principles that I follow. So first one is target E. coli. This is the number one cause of UTI. E. coli and friends. So friends meaning Klebsiella pneumoniae, Proteus, Enterobacter. So basically those bugs are all part of the Enterobacterales family. Number two is use nitrofurantoin as first line for uncomplicated UTI, so just a bladder infection. So it retains excellent activity against E. coli. Number three is reserve fosfomycin for uncomplicated UTI that are caused by multi-drug resistant pathogens if you have no other oral options. So there was an RCT that showed fosfomycin is not as effective clinically or microbiologically compared to nitrofurantoin. And so if you can't use nitrofurantoin, you can't use Septra, you can't use Moxclav, can't use Cipro. Really, fosfomycin is kind of last line. You're kind of reserving it for those really resistant bugs. Number four, pyelonephritis with or without bacteremia are treated the same way. So bacteremia does not necessarily mandate IV therapy or longer treatment, right? So the pyelonephritis, sometimes the organism will spill into the blood. It's not going to stay there for very long at all. And, you expect that pyelonephritis with or without bacteremia, you're going to feel pretty crummy, right? With fever, back pain, that kind of stuff. Having bacteremia doesn't change anything. So use IV only if there's no oral options. Sometimes that does happen. Patient cannot tolerate PO because they're vomiting from the pyelonephritis. Patient's going septic or they're too delirious and refusing PO. And again, the treatment duration is just 1 week for bacteremic and non-bacteremic pyelonephritis. So when do you treat asymptomatic bacteriuria? So for your purposes, there's only two indications: pregnancy and right before a genital urinary procedure that involves mucosal bleeding. But for your long-term care patients, there's really only just that one indication, as I don't expect any of your patients to be of childbearing potential. And if your practice does involve caring for pregnant patients, screening for bacteriuria is recommended at 12 to 16 weeks gestation or first prenatal visit if after 12 to 16 weeks gestation. These are the recommended agents from Bugs and Drugs. They also say you should do post-treatment urine cultures 1 week after finishing the antibiotic, and then monthly urine cultures for the remainder of the pregnancy. So, but I don't think this applies all that much to your patients. But this one here may be applicable. Some of your patients may be undergoing stent insertion, maybe cystoscopy, stone extraction, that kind of stuff. So for any genital urinary procedure with expected mucosal bleeding, you should send off the urine, and right before the procedure, you should have culture and sensitivity, so you know which drug to prescribe. I think the urologist should know to also provide prophylaxis. So this shouldn't solely be on you. Okay, is there any benefit to treating asymptomatic bacteria in elderly patients who do not meet those two indications? So unfortunately not. There's basically zero benefit and all harm. So one of the most common reasons these patients receive an antibiotic is a urine is often collected when they are delirious, and many times the culture and urinalysis come back positive, right? So most of them get antibiotics. So interestingly, when they studied this, patients who got antibiotics compared to those who did not had no improvement in their delirium anyway. And so, in another large cohort study of like over 2,000 patients with bacteriuria and altered mental status, but no systemic signs of infection, only 17 or 0.7% of those 2,000 patients developed bacteremia that was concordant with their urine culture result. Right, so altered LOC plus bacteriuria in the absence of signs of sepsis is really not that dangerous. So, therefore, the vast majority of patients who get antibiotics for biliary and bacteriuria end up being harmed by these drugs. So, harms of overtreatment. So, there are many, and some are obvious, some are not. So, some of these drugs, like Cipro, Septra, they have nasty side effects, especially for older patients. And with any antibiotic exposure, there's increased risk of getting fungal infections such as thrush or vaginal candidiasis, C. difficile infection. Antibiotic resistance is a well-known side effect of too much antibiotic use. And so if the patient has a real UTI in the future, it might be harder to treat because their bugs are now more resistant. Excess antibiotic use increases costs and generates more waste and greenhouse gases, especially if you use IV medications, because these produce a lot of single-use plastic and more garbage than oral meds. And there was one large study that found treating asymptomatic bacteria is associated with prolonged hospital stay, possibly because of drug side effects or patients kept in hospital longer for additional monitoring and awaiting culture results. And one of the less well known side effects is the negative impact on your own urinary microbiome. So this microbiome protects you from real infections and other nasty pathogens. So the urine's not actually sterile. It has its own unique flora that serves a protective function. And by killing it off, you risk having a real UTI down the road. And in one study, they found that there was an increased risk of UTI by threefold um, after treatment of asymptomatic bacteria at 1 year follow-up. And the more antibiotics that you take, the more your microbiome gets disrupted, which paradoxically may put you at high risk of getting recurrent UTIs. Now, some people try to look for exceptions to the rule, and they do exist. So, for example, do you do anything different if the urine culture grows, say, yeast, like Candida albicans? So, Candidaria is actually quite common in hospitalized patients, especially with Foley catheters, if they've had recent antibiotic use or diabetes, right? So if you're on lots of antibiotics, you've killed off your bacteria, what's left, it's the yeast, right? So most often it represents colonization, so I've almost never treated it when I see it in the urine. So you basically look for the same symptoms and signs of UTI as you would for bacteria. What if the urine grows Staph aureus? So this one's tricky because Staph aureus is not a typical uropathogen and is generally not found in the urinary tract. So it can be introduced into the urine by way of recent instrumentation or the presence of urinary hardware like stents or a Foley catheter. And the other way for Staph aureus to get into the urine is from the bloodstream. So the general rule of thumb is if you see Staph aureus in the urine and you have no urinary hardware, or recent urinary intervention, maybe get a blood culture because there might be an occult bacteremia. What if your urine grows a very resistant bug? It's ESBL or carbapenem resistant. So you generally don't treat it any differently. Asymptomatic bacteria does not care how resistant it is, right? So the only difference is for contact precautions if it's a carbapenem resistant bug. Um, so that's about it. And then what if the urine culture has high colony count? So that's not relevant either. So bugs can freely grow in the urine, especially if the patient has urinary retention, incontinence, or impaired hygiene. So the count does not really matter. Okay, so the best way to avoid inappropriate antibiotic treatment is actually not to obtain the urine sample in the first place. So it's very hard to ignore a positive result. So sometimes it's best not to even order the test. So I think educating the staff about true UTI symptoms and when and how to collect the urine is helpful, but this education only goes so far, right? It needs to be reinforced so people remember and apply the knowledge on a routine basis. So that's where EMR alerts or nudges might be helpful. I'm not sure what kind of EMR you guys use in your facilities. And so if you try to order a urine test, the software would prompt you to select the indication or remind you of the minimum criteria for ordering the urine culture. Some experts recommend removing urine dipsticks entirely from the facilities. So, these will often produce false positive results just due to the high prevalence of pyuria and bacteriuria. So this dipstick is not that useful and will probably lead you down the wrong path with the false positives. Another strategy is to remove urine cultures from order sets, such as for delirium workup. So it's very easy to just check off the urine when it's staring you right in the face. So some people might not think twice before ordering it, even when it's not appropriate. So this is just a summary table comparing asymptomatic bacteriuria and UTI. So the main similarities are you have bacteria in the urine and you have pyuria. So that's why the dipstick's not very useful. The main difference is asymptomatic bacteria has no real UTI symptoms, and you don't treat it unless patient's pregnant or right before a urological procedure. And if you have a real UTI, obviously you treat it. So just a few take-home points for you. So only collect the urine if the patient meets minimum criteria that I showed you. Okay, so this would minimize over-testing and over-treating. And if you do collect the urine, keep in mind that the positive predictive value of a urinalysis and urine culture in this population is really not that good. Because if you were to test the urine on a good day, it's probably going to be abnormal. So asymptomatic bacteria only needs to be treated in pregnant patients and before a invasive urological procedure. There is no other indication. There's some controversy about whether or not you treat it for early renal transplant period, but I won't get into that. And then if you treat asymptomatic bacteria in other situations, there's really zero benefit and it only causes harm. And finally, as cliche as it might sound, treat the patient, not the urine test. Okay, so with that, I'm happy to answer any questions.
Yes, can I? When I was finishing my hospitalist at Surrey Memorial a number of years ago, I was seeing not infrequently patients acutely admitted and diagnosed was urosepsis. At the time, I looked at numbers. Am I here? Can you hear me?
Yep.
At the time, I was surprised to learn, we talked about 10 years ago, that over 20% of septic patients were as urosepsis, like coming from urinary tract. So question two is does it still hold that many were presented acutely sick with sepsis would be source would be urinary? That's my one question. And then once you answer, if you can, then I'll have a comment about dipsticks. So please go ahead.
Yeah, so UTI is still very common cause of sepsis. It's really hard to tell if it's the cause of sepsis in these older patients, right? Many times, even in younger folks, if they're coming in septic, we're not always able to identify the source. I don't know what the data is exactly on whether it's still 20% or something else. Because it's very hard to diagnose much in this elderly population, right? Because many of them have dementia, they're delirious, you can't get a good history from them. But if they are coming in septic and you do the urine, of course it's going to be positive. Can you exclude urosepsis? No, you can't. So because they're septic, you're treating them for basically, possibly for pneumonia, UTI, intra-abdominal, right? So whatever broad spectrum antibody you put them on to cover widely for infection, it's likely going to treat basically everything, right? So it's really hard to pinpoint whether or not the patient who is septic but can't give you any history if that sepsis is coming from the urine. Because, like I said, if you test the urine on a good day, it's going to be positive, right? So positive culture does not equal infection.
I'm sure you know why I'm coming from. It is that, say, we elect not to treat and they fairly quickly get sick, and maybe it's kind of late or too late, and then family comes and asks, you have some positive urine test, and you didn't believe it was there, and so in a sense, so on my side, this is what we have to think. So to protect ourselves, but maybe well-being of patient. Now, how about concept of a urine dipstick to rule out and not rule in? And I'm having so many of those old fellows who get sicker and forget about cloudy urine, and nurses maybe pay attention, but we don't. Cloudy urine doesn't bother me, but then if they become restless or or they are not eating, or I had a today patient who is getting worse last 4 days, and I wish I had dipstick so I can rule out, but I can't now. And it would take 2 or 3 days to get analysis and culture. So what do I do? So my concept would be, and if my nursing home allows me to bring my own private dipsticks and to use it for my own, and then I'm considering it to rule out, not to rule in. If patient is doing not well and the dipstick is negative, this is it. I mean, of course, if it's positive, it is not for me that this is UTI. I still look for all other causes, as you were alluded, and most of the time might not be urine then, but to rule out, not to rule in. This is the kind of concept I am trying to coin to you guys. And last one, quick. I hope you still have time. And now this famous positive nitrate. It was my understanding that positive nitrates reflect active multiplication of gram negatives, in particular E. coli and gram negatives. So this was my understanding. So if you see nitrates, it suggests active division of bacteria rather than passive or whatever, ongoing presence of that. So can you comment?
Yeah, so the patient that you're describing with like not eating well or reduce activity, so that doesn't meet the minimum lobe criteria. So you wouldn't even be doing a urine test in the first place. Yeah, I see what you're saying, that if the urine dipstick's negative, it's helpful to rule out a UTI. But if you look at how many patients don't meet criteria for testing in the first place, how many dipsticks would you actually be doing? Is it enough to justify having the dipstick in the facility? And that's not something I can really answer. It's not, I'm not, it's not for me to say, but it's more just to kind of make it harder for people to order a test that will end up providing a false positive and leading to more harm, right? So in the situation where they do have the minimum criteria, and if you have a dipstick, great, but how often do they actually meet minimum criteria? Your question about nitrates, yeah, that's correct. It reflects the presence of fermenting gram negatives like E. coli. I don't actually know if that means there's active multiplication. I would imagine that if you have bacteria in the urine, there's always going to be multiplication. Some will die out, some will, divide. Again, that doesn't matter because if I have no symptoms, it's not a UTI. So the key point here is like look for the symptoms, because of the three things that matter most, like the symptoms, urine analysis, urine culture, the symptoms matter the most. Because if you give me a positive urine culture and urine analysis, you can't diagnose anything with that. You need the clinical, you need the symptoms, you need to correlate clinically.
Hi,
Hi, so I have a question. When it comes to like patients who are like quadriplegic, who have no sensation, who can't feel a burning sensation, symptoms do you go by then?
Yeah, good question. I assume they're catheterized, right?
No, not catheterized either.
Okay, so there's two potential scenarios. So they're either catheterized or they do intermittent self-catheterization. So yeah, that's very tricky because you can't really rely on the local symptoms like dysuria, frequency, that kind of stuff. So in those patients, they kind of know their body pretty well. So the type of symptoms they tell you is, oh, feeling of unease or autonomic dysreflexia. They might still have the fever. They might feel spasms in the bladder area. It's very non-specific, so I'm not sure how evidence-based these symptoms are. But when you see enough of these quadriplegic patients, there seems to be some um, common theme here, and so that's kind of what I rely on mostly, like autonomic dysreflexia, bladder spasm, fever, feeling of unease. I mean, that's the best you have, right? Because the urine is likely going to be abnormal anyway on a good day, just because they're catheterized or they're retaining urine. So it's the same issue as with elderly patients. They're going to have a abnormal UA urine culture most of the time.
Okay. So I think it was in Choosing Wisely that I read about going by neurological symptoms.
Which ones?
I think in Choosing Wisely that I read for people who can't, describe to go by neurological symptoms. So would you look into like their altered mental status, like confusion or just
Again, that's not specific for UTI, even in quadriplegic. So if you have altered mental status plus some other symptom, then sure. But altered mental status alone, I don't really count that as a symptom because, like I said, if you
okay?
do the urine on a good day, it's probably abnormal because their
Yeah.
bladder's not functioning like a normal person, right?
Yeah. Okay, thank you.
Hi. So one question I have is like you sort of suggested not to do a urine culture if the symptoms are there. But my concern would be that you may treat them and then they continue to have symptoms and you don't know then what bacteria you can or what antibiotics you can now switch to. And the other is in long-term care, a lot of the people have low EGFRs, and so you can't really give the macrodantin with their low EGFR, or do I misunderstand that?
So the first point is when I said don't check the urine, that's not my recommendation. Is actually a guideline recommendation that applies to primary care, not long-term care. So if you've got like a young or middle-aged female who comes in with classic symptoms, that's what the guideline says. You don't even have to do urine culture. So as an ID doc, I see the pros and cons of that, right? You don't do the urine test, lower costs, use less resources, etc. But from my standpoint, because I'm biased, I do urines because I see a lot of these folks who are not complicated. And when you do a urine on everyone that you suspect has a UTI, it contributes to the antibiogram data, right? So that because that data is used to inform empiric treatment. So if you're not doing urine cultures on these young folks, then you're probably skewing the antibiogram data towards more resistant pathogens because you're only collecting it if someone's like complicated or if they're failing treatments. So more likely you're going to run into resistance. So that's what the guidelines say for like if you're a family doctor, don't do it if the patient comes in with classic symptoms, but definitely for long-term care, you will do it because they're more likely to harbor resistant bugs. What's your second question?
The macrodantin and
Oh, yeah.
the low EGFR.
Yeah, so the guidelines you can find in Bugs and Drugs or First Line, and it'll tell you if you can't use nitrofurantoin, you can use other things. So I guess for Septra, it's only 3-day course. So you kind of have to weigh the risks and benefits of using Septra in CKD, and if they're on some other medication like ACE inhibitors, where there's a potential for hyperkalemia. Even with a short course, you might not want to. So the other options would be like beta-lactams. So cephalexin, amoxiclav, cefixime, Cipro. Cipro is not first line. I kind of reserve it if there's no other agent, just because of the nasty side effects in older folks. So so I would use Cipro before I use fosfomycin, but that's just my personal preference. Yeah.
I'll just make a comment about we got to be careful, not even just with the elderly, but they do need an exam. Years ago, and this was an office-based patient many years ago, and she came in all upset because she'd been seen at the walk-in clinic and they treated her for her bladder infection. She was 40 years old. And so, I sort of, no culture was done. So I did at the time, I ended up ordering a culture, but I also examined her and sort of felt that there was this pelvic mass, and she had a large fibroid on the ultrasound that was pushing up on her bladder. But she also, the reason why she had a sudden change is that she was also pregnant, had an ectopic pregnancy that was eroding into her bowel. So it's important to make sure you examine all these patients, even the the ones that are coming in your office, and make sure that like there's more things that cause UTI symptoms than the UTI. So
yeah, in that scenario, I have encountered it. Patients with these urinary symptoms, they're getting multiple antibiotics, they're not improving, they refer to me. And so that's usually a red flag, because there's probably some other pathology going on if they're not getting better with antibiotics. So you probably will do imaging or that kind of stuff. So
Yeah, Sandra, go.
The only comment I wanted to make, and I really appreciate your talk, thank you so much. For us, we have family expectations, and they come to us having been in and out of emerge, being told by the ER that their loved one has UTI, and the common diagnosis is recurrent UTIs. And so whenever there's a change in behavior, I'm commonly told, well, we know when my loved one does this, it's a UTI, or they fall, it's a UTI. And we have families, and certainly the majority of them I can talk to and I can educate them, but there are some families out there, there's no they're going to be upset if you do not give them an antibiotic. And I guess my one comment would be, if you could educate emergency physicians, I would really appreciate this, because I think a lot of my grief comes from the fact that either my patients come back from having fallen and having a fracture, and they've been diagnosed in emerge with the UTI, and the care home missed it, and then they get angry with us, or they just have these recurrent UTIs that I know are not recurrent, but the family, it takes so much energy to educate. And sometimes it's exhausting with difficult families. It's just so much easier to give an antibiotic. So my only recommendation to move this forward, if we could, because a lot of what you said, I've heard a lot from these talks, Dr. Kevin Afra speak, and others. I feel our ER colleagues, and not to say they're doing anything wrong, but I'm sure you've seen it in the hospital. It's commonly people get diagnosed with UTIs. And just, that's my comment. And thank you so much.
yeah, you're welcome. Yeah, I mean, you touched on a very important point there. I can't educate everyone, right? If you look at the studies, 80% of clinicians prescribe antibiotics inappropriately for asymptomatic bacteria. So the vast majority of us are doing the wrong thing, which then gives the illusion that that is the standard of care, which then tells patient that if you're not giving my family member treatment for the asymptomatic bacteriuria, you're doing the wrong thing. So we've done this to ourselves, really. So I know what you mean. It takes a lot of time and energy to talk patients or family out of it. And sometimes it's exhausting, and sometimes the easiest thing to do is just give them the antibiotic, but that basically reinforces their false perception of what's going on. So I don't think education alone is going to help. Like this concept of asymptomatic bacteriuria is not really that hard to understand. And I think it's just because we've been teaching it wrong to students, teaching it wrong to patients, that we're kind of in this rabbit hole. And the small percentage of people who are trying to do it correctly are viewed as doing it incorrectly because the vast majority are doing it the wrong way. So yeah, I feel your pain.